let's learn a bit more about the pathophysiology and the mechanism of disease. When a burn occurs on the skin, it causes changes within the skin that could be divided into sort of three regions or three zones. These zones of a burn were described by Jackson in 1947, and so it is also called the Jackson model. The first zone is the zone of coagulation. Then it's the zone of stasis on the outside, and then the furthest part is the zone of hyperemia. So the zone of coagulation is essentially the point of maximum damage. In this zone, there is irreversible tissue loss due to coagulation of proteins. Thus, you get coagulative necrosis. Surrounding the coagulation zone of necrosis is a zone of stasis. Now, in this zone, it's essentially characterized by decreased perfusion. This ischemic zone may progress to full necrosis unless the ischemia is reversed. At the very outside is the zone of hyperemia. In this outermost zone, tissue perfusion is increased. The tissue here is invariably recovered unless there is severe sepsis or prolonged hypoperfusion. Again, the stasis zone is characterized by ischemia and may progress to full necrosis unless the ischemia is reversed. Therefore, the main aim of burns resuscitation is to increase tissue perfusion here and prevent any further damage, any damage becoming irreversible. So that is a general pathophysiology or mechanism of disease concept of burns. When you assess a burn, it is important to know the cause of the burn, as we have learned, such as if it's a thermal or radiation burn. The other important aspect of a burn assessment is to know the depth of the burn. To make it super easy, just think of burns as initially being superficial burns or deep burns. So let's zoom into the skin here to look at what happens in a superficial burn and what happens in a deep burn. Let's take a look at a superficial burn first. If it's a superficial burn, it will cause damage to the epidermis and the upper dermis only, so like the papillary layer of the dermis. Again, you have blood vessels here, capillaries. Superficial burns will damage the keratinocytes, which are your cells in the epidermis, and will also activate an immune response. So it will activate immune cells around the area, such as mast cells and macrophages. The damaged keratinocytes, the mast cells and the macrophages will secrete pro-inflammatory cytokines, triggering an immune response. The cytokines will stimulate nerve endings around the dermis. The sensory nerve endings here can be the ones that detect pain, for example, and pain is an important feature of superficial burns. Some cytokines will cause increase in vascular permeability. The increase in vascular permeability will cause fluid to leak out and may lead to interstitial edema. As the fluid leaks out, it can result in hypotension. Remember that the increase in vascular permeability causes fluid to leak out. The fluid can actually accumulate in one area, causing a blister on the skin surface. The sensitive blister can rupture and release fluid onto the damaged skin surface. Thus, superficial burns have a moist appearance. The cytokines secreted by the cells above will also cause concurrent vasodilation, causing further hypotension in severe cases. The vasodilation contributes to the warmth in the area, as well as causing blanching of the skin and erythema. Blanching means that when you press on the burnt skin surface, blood will quickly fill it up because of the increase in blood flow to the area. The blanching skin is a feature of superficial burns. In deep burns, you have more than just damage to the epidermis and the upper part of the dermis. You have damage all the way down, extends all the way to the hypodermis, so it's a pretty deep burn. Deep burns can thus damage blood vessels in the skin. Because you have damaged blood vessels, everything will leak out. You have no blood supply to the area, so you eventually get this dry, non-blanching surface. It is dry and inelastic. The non-blanching dryness is an important feature of deep burns. Further, deep burns extending to the reticular layer of the dermis can destroy nociceptors and other sensory nerve fibers. Initially, pain can be detected, but as the sensory nerve fibers are damaged, you get hypothesia. So you get reduction in sensation. Loss of sensation is an important feature of deep burns. Obviously, not all your blood supply is damaged or your blood vessels are damaged. The functional blood vessels will react to the cytokines produced around the area. The vessels will increase vascular permeability, which will cause fluid to shift out, causing interstitial edema. So fluid shifts out from the intravascular space, so the blood vessel, and this will into the interstitium. And this huge amount of fluid coming out of the vessels will result in hypotension, so circulatory shock even. Hypotension as a result of the shift of fluid occurs more in deep burns rather than superficial burns. So now that we know the pathophysiology of superficial burns and deep burns, let us learn a bit more about the classification of the burn depth. Again, burn depth can be broadly divided into superficial and deep burns. Superficial burns can be further divided into superficial epidermal burns and superficial partial thickness burns. In superficial epidermal burns, only the epidermis is involved, so the very top of the skin. The most common cause here is your regular sunburn when you get a dry and red skin, which is painful. The epidermis layer is the only layer involved. On a side note, superficial burns are not included in the assessment of the total body surface area burn. In superficial partial thickness burn, you are causing damage all the way to the papillary layer of the dermis, so the upper dermis. And so because you are going all the way to the upper dermis, you are allowing the blood vessels to increase permeability, leading to blister formation, which then can subsequently rupture. The feature of the burn is red, moist weeping with rupture and unruptured blisters. The burn here is very painful. Again, in superficial partial thickness burns, your epidermal and papillary layers of the dermis are involved. The important features here are blister formation, rupture of blisters causing a weeping, moist injury. As mentioned before, and I will mention this again, superficial burns is characterized by a blanching injury. So when you press your finger on the area pressured will return to its normal color because of the normal perfusion. The other important aspect of superficial burns is that the sensation is still working. It is normal, and so you feel pain. Deep burns are totally different. Deep burns involve all layers of the skin. The important feature of deep burns is that it does not blanch with pressure, and there is minimal to no pain. No sensation due to damage of nerve endings in the area. Deep burns can be easily divided into deep partial thickness burns and full thickness burns. In deep partial thickness burns, the burns are partially deep. They cause blisters which easily rupture and come off. The surface of the skin can be pale if blood supply is lost, or red if there is extravasation of red blood cells. In partial deep thickness burns, you can get damaged blood vessels, which means when you press the skin surface, it will be non-blanching. And also, partial deep burns may damage sensory nerve fibers, causing a decrease in sensation. In partial deep burns, the skin layers involved are the epidermis and all the dermis layer. Full thickness burns are the worst. Here, all the skin layers, including the hypodermis, are involved. The burn is so extensive that the skin may look waxy white, leathery gray, or charred black, depending on how deep it is, duration of the burns, etc. The burnt area is not wet because no blisters are forming. It is usually dry and inelastic. the sensory nerves and the blood vessels are definitely destroyed, and so you have no sensation and no blanching. In full thickness burns, you have destruction of all skin layers, including the hypodermis. There's actually a fifth classification of deep burns, but we're not going to talk about it here because I feel like it causes more confusion than help. Referring a burn to the burns unit is very important. We talked about referring certain types of burns to the burns unit, such as chemical burns, electrical burns, and inhalation burns. But how about the burn depth? Well, we always refer full thickness burns, and also burns greater than 10% of the total body surface area. And this does not include the superficial epidermal burns. So what does this total body surface area mean? When assessing burns, it's also important to calculate how much of the body is burnt, or the size of the burn, or we refer this to as the total body surface area. A good way to calculate the total body surface area is to use what is called the rule of nines. It's a great rapid assessment. The rule of nines is where the body is divided into areas of percentage, which are divisible by 9, with the exception, for example, you have 4.5%, 9%, or 18%. So if we look at a human from the front and the back, the front of the face is 4.5%, the back of the head is 4.5%, 9% front of the chest, 9% upper back, 9% stomach, and 9% lower back. For one leg is 18%. So 9% for the front of the leg and 9% for the back of the leg. For the upper limb, it's 9% total. So it's 4.5% at the front and 4.5% at the back. I hope that makes sense. And the genitals and perineum is 1%. So to summarize, the head and neck total is 9%. The chest, front, and back is 18%. The abdomen all around is 18%. One leg is 18%, and one arm is 9%. And the genitals and perineum is 1%. So all should equal 100%, if I did it right. Another quick way to measure total body surface area is by using what's called the Palmer method. Here, the person's palm and fingers will represent 1% total body surface area. So for example, they have burnt an area of their body and their palm and fingers covers this burn. This represents 1% total body surface area burnt. The Palmer method is useful for small scattered burns. So remember, we briefly mentioned when to refer burns to the burns unit, such as the type of burn as well as the depth of burn. So for example, full thickness burns or burns greater than 10% of the total body surface area. But this does not include superficial epidermal burns. So how about some other factors which will make one refer to a burns unit? Well, things that potentially need referring to a burns unit include burns to the very young and very old, special areas such as the head, major joints, genitals, hands, and feet also need referring to a burns unit. Burns in pregnancy as well as circumferential burns are very serious. Circumferential burns especially can progress to what is called compartment syndrome, where pressure and edema builds up in the muscular compartments, causing diminished neurovascular supply to the area, which can lead to irreversible damage and amputation of that limb or area if not saved early. I hope you enjoyed this video on burns.